the spaces. So, for example, I don't remember, I have to reflect more, but on the spine, on the periventricular, on the brainstem, I believe, and then close to the cortex. So these are the 4 areas, and you have 2, and you meet the criteria for space occupying, and then you have time occupying. You find different onset images, and so the patient met the criteria. And I really love the point that Ravi made, that of course you have to consider a broad differential diagnosis, but if the patient has a criteria for MS, how much could, or what could you do with a positive ANA just to rule out lupus, for example, that could also present like a demyelinated presentation. And so kind of take that in mind, that I mean, here we could rule out NMO, antibodies, and as I said, lupus and Sjogren's, but really with the criteria met, you should consider MS. In this case, that was a diagnosis. It was a really good case, and I really suggest and recommend you join us on Patreon.
Thanks so much, Aurelia. I would make the same recommendation. I've been a long time subscriber, but I miss most of the sessions still, just because they are such beasts at creating more content than I can. I'm much better at chugging watermelon. Let me say that than I am at ingesting almost anything else. So Steph, actually, you have a cold case you'd like to share with people. So I will need some help with this cold case. Can we have at least one person who would like to help Steph and me, I guess, with this case, and we can get going?
And I'll just thank you guys in advance. I love doing Wednesday VMRs. I love it when we're on service, because a couple of times I've taken advantage of all of your fantastic clinical reasoning minds to really take one step forward on a current case. So I'm excited to do that today too.
And those are the situations where we definitely thoroughly read the chat before we end the meeting for ourselves, since we don't get to look at it during the session enough.
Hey, I linked a human DX case that Laura had created, and we just released it today on human DX. So if you guys want a challenging case to do afterwards, I recommend seeing if you can solve Laura's case as well.
Thanks, Travis. Thanks, Laura. Let me click on that and then go back to the meeting. Okay, Kirtan has volunteered, but we'd love to have anyone else. He is willing to yield since he is such a frequent and masterful discussant. Anyone else want to discuss with us? Going once? Twice.
How many do you need? You need just, what's the format?
Anybody else want to join Kirtan, and we'll just get going. We won't say no to Kirtan, of course. Going twice.
I can help Kirtan and jump in if you need another person. I'm here, so
that would be awesome.
Oh,
let's just do we're all just here to help Steph's patient. So we'll have a good discussion.
I already feel lucky to have a Zavin, Kirtan, Travis consult.
Oh, we have someone. Please, I don't want to mispronounce your name. Would you mind unmuting Mr. or Dr. Singh and saying hello?
Hello, can you guys see me?
Yes, sir.
Oh, hello. So actually I was in the library, so I just need to find a quite personal room. That's the only way I can talk to you guys. So finally I found this place. So yeah, I would love to discuss. Yeah, I would love to jump in.
And how do you pronounce your name?
Just Simran Singh.
Jess Simran. Nice
Yes.
to meet you.
Yeah.
And where are you in the world, and what level of training are you?
Oh, I just completed my MBBS medical school from India, and now I am at Mayo Clinic, Rochester. I'm doing research in gastroenterology department.
Wonderful. Thanks for joining and for volunteering to discuss. Looking forward to it. All right, Steph, tell us about this patient of yours.
All right. The chief concern is chest pain. And let me give you a fair amount of the story to begin with. This is a 52-year-old woman who has end-stage renal disease, known coronary artery disease with stents in December of 2020 in the right coronary artery and left anterior descending artery. And associated ischemic cardiomyopathy, but with a recovered ejection fraction. It was 35%, but on medications and with improvement in her ischemic heart disease, her ejection fraction is now 55%. Who comes in with chest pain during a bout of hypotension and dialysis yesterday. Let me actually stop there, and then I'll give sort of another aliquot of history subsequently, but let you work with that to begin with.
Awesome. Thanks, Steph. Jess Simran, do you want to get us started and just share your thoughts about what we've heard so far?
Okay. So I think this is the case of chest pain. So whenever we think of chest pain, we always have like we go by the anatomy. We have the lungs there, we have the heart there, pleura, pericardium, we have the muscles and all the chest wall. It could be the pain related to chest wall as well. But as you said that this patient has end-stage renal disease, and this patient also had previous history of right coronary artery disease and stenting. So two things that I should be keeping in my mind. First of all, end-stage renal disease can cause uremic pericarditis. That could be the one cause of chest pain. And the other thing I would love that he has the previous history of ischemic chest cardiac pain, so that the recurrence of another episode of ischemic cardiac pain is the most common probability here for this patient, because after stents also a lot of people are not compliant with their medications, and even if they are compliant with medications, we have high probability of having another ischemic cardiac pain in those patients. So these are the few things I would keep in mind regarding this patient. But if we go by the simple anatomy, all the causes of chest pain to be kept in mind.
Wonderful. Hey, I just realized, so since we have 4 people in the mix, why don't we pair up as usual? So Jess Simran, you and I can discuss this aliquot, and then Kirtan and Travis can pair up for the other one. Does that sound okay, y'all? Okay, cool. Thumbs up from Travis. Sounds good. Okay, wonderful. So our great initial sort of framework for chest pain, anatomic, and then taking this patient's kind of known history and unique characteristics already to sort of focus on one of the most probable causes. Yeah, I think that's perfect. I want to just add for the students listening, just a teaching point about just how effective our medical therapies are for systolic heart failure. So it's very common for somebody to have really bad cardiomyopathy, dilated cardiomyopathy, whether it's ischemic, whether it's non-ischemic, almost any cause. But we learned that, of course, beta blockers, ACE inhibitors, and ARBs neprilysin inhibitors in combination, spironolactone and other mineralocorticoid receptor antagonists, SGLT2 inhibitors, all of these classes of medications prolong survival in patients with systolic heart failure, right? And it's not uncommon at all for somebody to go from having an EF of 20 or 30% and having that EF recover on that medical therapy. And this is a patient who has benefited from those benefits. The other possibility is that the EF was acutely impaired in the setting of an acute ischemic insult. And then after reperfusion, potentially, if these were stented in the setting of acute coronary syndromes, the improved perfusion in a viable myocardium can help the pump function improve and the EF recover. So just, and by the way, I want to make a broader point in general that there's so much we can learn from patients, not only from their current presentations, but by looking back and sometimes way back in their medical histories and just seeing that natural history of both the disease and the treatments, with an N of 1 at a time, and eventually compounding and compiling that experience. Anyway, so just some commentary on that. In terms of just this timing with dialysis, I think one question that would be helpful for me, Jessimaran, is like to know that what the hemodynamics were happening during the dialysis session, because it's so common for people to develop hypotension during dialysis, right? And if the episode of chest pain coincided with the episode of hypotension, that would be a really good narrative for essentially stable angina occurring in the setting of, stable coronary disease, and then a decreased perfusion pressure, a decreased sort of diastolic pressure that drives the flow across the coronary lesion. And then it resolves when the episode of hypotension and or dialysis resolves. If that was the case, I'm guessing that the patient wouldn't still be on step service, but we'll see. And then the other thing I want to emphasize for everybody is how important it is to know people's coronary anatomy, like as of the most recent cath, because just because the RCA and the LAD were stented doesn't mean that there's not a remaining tight left circumflex lesion, for example, right? And some recent trials, including the landmark ischemia trial in NEJM, has shown that when people come in and they have an acute coronary syndrome, and it's thought that the culprit lesion for this current event is coronary artery X, right? Be that the LAD, circumflex, RCA, whatever. But at the same time, during the angiography, you see that there's also an 80% lesion here and a 70% lesion there. That stenting those stable lesions doesn't improve outcomes. And we've generally had a sense that that's the case for a while. So don't assume that just because somebody, a month ago had a cath and had 2 vessels stented, it doesn't mean that there's still not significant stenoses elsewhere, and that there couldn't be a setup for a phenotype of stable angina, either with exertion or when the pressure drops. Okay, let's stop there. Steph, give us some more.
So I'll sort of give you a chronology leading up to this event. She's been on dialysis for some time and has had bouts of hypotension during it, but never gets symptoms during that. But she acknowledges with us, my blood pressure drops sometimes, but she usually feels fine and isn't sent to the emergency room. Yesterday morning, she woke up feeling perfectly fine. She took all of her home medicines as she always does. And I noticed Travis put a pearl in the chat about patients often are told to modify their medications on day of dialysis. This woman has always taken her home medications, which I'll include in this aliquot, and took them before the session. In the middle of the session, she suddenly had a drop in blood pressure. We do not know how low. She doesn't know. We don't have records from that, but the blood pressure dropped. And unlike prior episodes, she felt badly with chest discomfort, really a pressure, some sweating, left-sided headache, and blurry vision. This lasted for about 5 minutes. She was treated with a small fluid bolus. I don't know how much, and then supplemental oxygen, although we do not know that she was actually hypoxemic at all. And everything resolved in 5 minutes. But given the severity of the episode of her symptoms, she was sent to the emergency room. I will fill in the rest of the medical history, including the medications for you, because I do think it's salient, and probably give you the exam and then pause there one more time. So her pertinent medications are, she remains on dual antiplatelet therapy with aspirin and ticagrelor for her stents. She is on metoprolol. She's on a statin. And then she's on furosemide of 40 milligrams twice a day. She still makes urine. And that's it. Otherwise, there's really no contributory factors in her family or social history or health behaviors, nor allergies. Her vital signs are normal temperature, heart rate in the 50s, blood pressure 110s to 120s over 60s to 70s throughout her entire time in the emergency room. No hypotension at all with us. A normal respiratory rate, 98% on room air. And I will say her exam is really pretty normal. She's got a functional fistula in her left arm. Her heart rate is regular, just a touch slow, as you can see by the vital signs, but no murmurs, no rub. And her lungs are clear. And she, by jugular venous exam, by visualization, it looks like her jugular venous pressure is probably 6 centimeters of water, normal. No lower extremity edema. And let me stop there now that you've gotten a little more history of the episode and see what she looks like.
Hey Travis, do you think I should go?
Yeah, Kirtan, go ahead.
Yes. So thank you for presenting all the data, Dr. Sharman. So first, I was thinking about what is the pathophysiology of the condition we are dealing with. So I was wondering that whenever we are dealing with chronic kidney disease and end-stage renal disease, that what are its implications on cardiovascular system? So we know that when the uremia is present, when the levels of PTH will be high because of secondary hyperparathyroidism, lots of things are going on, and that can cause cardiac remodeling. So that can even cause dilated cardiomyopathy, as in our case, but it can sometimes even cause a mixed cardiomyopathy. So a bit of hypertrophic cardiomyopathy as well as dilated cardiomyopathy. And what are the implications on coronary artery itself? So as the Zevan alluded to, that we have to be vigilant about a possible stenosis there. And that's why we have the role of something known as CACT, that is coronary artery calcium score. That is what's the level of calcium there. Because with renal disease, we know that levels of calcium and phosphorus are in constant flux, and that can accelerate the process of atherosclerosis. And so we have to be vigilant about possibility of coronary artery disease. Another thing I was considering, that the patient has been on dialysis since a long time, that what if there is some sort of infection, but later on when we got the more data, the evidence of infection was on lower side, but still the fact that heart rate is low is concerning me. And as Jasimran alluded to in first aliquot, that what if we are dealing with pericarditis? Now we don't have evidence of pericardial friction drug, but it again raises the concern that what if initially it was simply pericarditis, but now we are dealing with pericardial effusion. Because we know that in hemodialysis patients, sometimes patients are on heparin, and patients are on antiplatelet drugs, lots of things, and that can trigger the bleeding into the pericardial space, and hence we may be dealing with cardiac tamponade kind of pathology. So that is interesting thought. Another point, that since the blood pressure was initially low, what if we are dealing with some kind of shock kind of thing? And now, as I alluded to earlier, that what's the role of coronary arteries? So what if we are dealing with supply demand mismatch kind of thing? Let's say if there is not a focused stenosis, but if there is a supply demand mismatch, still the ejection fraction won't be enough to supply blood to the brain. And the evidence of blurring of vision and unilateral symptoms makes me wonder, what if that patient experienced a transient ischemic attack during that time? And now what can cause transient ischemic attack? So first thing is cardiac etiologies. So as I alluded to, that maybe cardiac dysfunction is there in the form of ejection fraction. What if the patient had electrolyte disturbances like potassium disturbances which triggered an arrhythmia? Because an arrhythmia is very common in end-stage renal disease. Many types of arrhythmias can occur: atrial fibrillation, supraventricular tachycardias. All of them are capable of dislodging a clot, and it can go into the brain and cause transient ischemic attack. So that is one of the possible thought. And I guess I have jotted down all my findings in this notebook here. Last thing is that in one of the podcasts, we have something known as Core IM Reasoning podcast, which is handled by Dr. Nick Shackett and Dr. Art from New Zealand. And in that, they mentioned one case that how ticagrelor is notorious for causing dyspnea. And there are numerous mechanisms for that. But sometimes just stopping ticagrelor is the best test you can do. You stop the ticagrelor and the patient dyspnea, chest pain, everything will go away. So that's the last possibility, that medication side effect. Once we have ruled out all the sinister pathologies like coronary artery disease, possibility of cardiac tamponade and cardiogenic shock. So those are my thoughts, Ravi. It's a complicated case. So can you help me how to zoom in further?
That was phenomenal, Kirtan. And I don't think I could do the justice that you did kind of talking about the pathophysiology of the things that you're thinking about. And, I think the first thing that you focused on, was the cardiac cause. And, is there some sort of, supply demand mismatch? And, you think when someone's getting dialysis, blood's leaving the body, it's getting cleansed and then it's going back. If patients are taking blood pressure medications, maybe she took too many, maybe her blood pressure when she goes on the machine is a little bit low to begin with, but during dialysis, you can get hypotension. I always think of it like a coronary steal. It's one of the common things, when I finished residency, patients would always come in because we had a dialysis center by the ER. And like every day, it's like someone chest pain from the dialysis center. It's almost like a stress test. And knowing, one, the reason why she's on dialysis. I wasn't sure, Steph, if you mentioned the exact reason why she was on dialysis. It's just one of the things I think of. Was her kidney failure from lupus? Was her kidney failure from some sort of uncontrolled hypertension? That will tell me a little bit, I think, a lot of her background. I know she has coronary artery disease, but did you include that and I missed it, Steph, why she was on dialysis in the first place? Or
I did not. I actually don't know. I didn't look too far back. She had a prior history of hypertension that resolved once a dialysis was initiated. So I think it could have been hypertensive, but certainly there was no signal in the chart of other kind of major systemic condition other than that, but I'm not certain.
Okay. And focusing on the heart, it looks like her last, she had a heart cath with stents in December. And if this is a current case, that was about 9 months ago. I was told that, hey, a stress test is good for about 6 months. A heart cath is good for about a year. And you generally don't need to repeat these things unless there's some compelling reason that you need to look again. Either there's a great story with positive cardiac enzymes, or there's a good story with some EKG changes. Those would be, hey, let's go and take a look and see what's going on here. This person has disease, and it's likely that the acceleration of the disease process in this is a 52, or this is a young person. So this person has some obvious comorbidities that has led to these end organ failures. So more than likely, they're going to be, accelerating on the development of either more plaques. I don't know what their BMI is, what their dietary history is, what their lipid panel is. But that's one thing I'm going to focus on. The other thing I think is what you guys talked about earlier is what other organs can be affecting you. We localize chest pain. Is it lung? Is it PE? Is there something else around the heart that's causing this pain? I didn't get any whiff of that on the examination. The lungs are clear. There wasn't really anything in the history, like she's been coughing, she's got pedal edema, she has anything else that I can kind of marry with that. Looking at her vital signs, she's bradycardic. Is the bradycardia because she took too much metoprolol, or is there some other cardiac component that's causing that? The O2 sat's good. The the fistula on her arm looks like it's it's not bleeding. A common reason sometimes people get hypotensive on dialysis is because they're bleeding from their shunt or fistula. And the next thing that I want to see is the EKG. I think that's always my pivot point for chest pain and shortness of breath. It pivots me towards calling a STEMI and getting the patient to the cath lab within 60 minutes, or it pivots me away to alternative diagnosis. Does the person have a pericardial tamponade, like Kritan mentioned? Is there low voltage? The three things that cause low voltage, the most common, is there a pericardial effusion? Is there COPD? And is there obesity? Those are three things that I'm looking through and I'm going on there. Do you have electrical alternans? Is there ST depression, T-wave inversions? So those will all tell me where to go from here. So that's my next kind of pivot point, I think, before I decide on what labs and imaging that I want to get.
Wow, I just love hearing all of your discussion, and even just a lot of implicit teaching through the additional questions being asked. Zavin asked me actually just now, we're on mute, did you tell us everything that there was on that cath in December? Meaning, was it only bad disease in the RCA and the LAD? And that is the case. The left circumflex had some very mild luminal irregularities, as we say, but no major stenoses that they left alone. So let me deliver to you her initial troponin and her initial EKG, and I will give for comparison the two more recent EKGs we had on file. So her initial troponin was 0.05, which is just a touch above normal for our lab, normal being 0.02 or less. And let me just tell you the history also. She has been totally asymptomatic since that 5-minute episode in dialysis. And she's really asking us, hey, can I go home? Point of care troponin 0.05. And let me first show you the admission EKG. So I'll have Zavin, I sent the files to him from my computer here. I'll have Zavin share screen and probably pause and let you digest that. Maybe make a few comments, and then I can show you the two prior ones we had for comparison.
Cool. Okay, so this was the one, Steph, September 14th?
This is on arrival.
Okay. Jasimran, do you want to go through this EKG with us?
Yes, you caught me on my weakest topic, so I will try.
Good.
Okay, so let's start with V4, V5, and V6. I can see T-wave inversion in V5, V6 leads. If we talk about lead 2, PQRS, is it possible that these are U waves because of hypokalemia? Maybe after T wave in the lead 2, after T wave, I have another wave before the P wave is coming. I don't know how exactly it can be U wave. I'm not sure if we talk about the baseline, and we have I think you can go ahead. I'm so confused.
Jasimran, that was actually both spot on. Really good catches, and I think everybody, all 32 of us here on this call, will agree that EKGs are extremely challenging and feel like a weak spot, or at least at some point have felt like a weak spot for every single one of us. So this is I'm really glad to have this opportunity to look at an EKG with everybody and just kind of share both my interpretation as well as just a couple of general points about the approach. So one thing that I almost always emphasize when sort of helping people kind of think through EKGs and get better at EKGs is just acknowledging the the overwhelming visual nature of looking at a 12-lead cardiogram. If you think about how much like visual information is in front of us right now, it's just like, right? So, so it's really helpful to just like acknowledge that and then have some system that allows you to focus. Because here's the truth. For most components of interpreting an EKG, for rhythm, for looking at intervals, for the axis, for QRS duration and bundle branch blocks, for, you know, you don't need to be looking for hypertrophy. You don't need to be looking at the entirety of the visual information in front of you, right? For each of those things, you only need to look at like one lead at a time. And that's just really helpful to like acknowledge and be like, okay, I'm looking at rhythm. Where do I need to be looking? Oh, okay, only lead 2, right? For axis, where do I need to be looking? And then try to have resist the temptation to look elsewhere, you know, during that time. Just look at like one thing at a time, right? By contrast, whenever I'm on rounds and somebody's reading an EKG, almost always, like I'm looking at their eyes and their eyes are doing this. They're just like, it's like they're in REM sleep. They're just like looking everywhere and are clearly actively overwhelmed by, you know, by all the squigglies in front of them. So real quick, I'll share my approach of sort of the sequence in which I look at everything. My mnemonic is rhythm, QI, ACS. For rhythm, I only look at lead 2. And in this case, we have a P wave before each QRS, QRS after every P wave. So this is, and the P wave is upright in lead 2. This is sinus rhythm. Moving on. The Q in QI stands for the QRS duration, which in this case is narrow. So there's no bundle branch blocks. There's a mild widening, but non-specific. So that's good. We can move on. Quick note. The reason I have looking at QRS duration and bundle branch blocks early in my system is because if there is a left bundle branch block, then everything else about the EKG interpretation is going to be affected by that. You can't comment on hypertrophy. You can't comment on axis. You can't, interpret the ischemic changes as well. So it's important in your mind to recognize, a bundle branch block, especially a left bundle early on. All right, I is for intervals. PR is fine. QT is actually a little bit prolonged. Okay, noted. Rhythm, QI, ACS. By the way, QI, quality improvement, ACS, acute coronary syndrome. That's how you remember. Okay. The axis is leftward. It's positive in 1. It's negative in F. So it's pointing left and up. The main causes of that, other than left bundle, is an old inferior MI, which there isn't because there are no Q waves here, and a left anterior fascicular block. So this patient has a left anterior fascicular block. Fine. Rhythm, QI, ACS. C is for chambers, looking for hypertrophy. The P waves don't suggest in 2 and V1 any atrial enlargement. There is possible signs of sort of prominent voltage in the left ventricle, but in the setting of the cardiomyopathy, it could just be from that. Okay, and finally, the S stands for ST T wave changes, and that's the ischemia. And it's the ischemic changes for which you have to look at every lead. That's why a 12-lead EKG exists, as opposed to just having a couple. And I always look at the leads in groups. First the inferior leads, then the septal, anterior, apical, lateral leads, and you're looking for 3 types of ischemic changes: ST deviations up or down, T wave inversions. Those 2 types of changes denote active ischemia, and then Q waves suggest an old scar. So in this case, in the inferior leads, the ST segments are flush, they're isoelectric, the T waves are upright, there's no Q waves. All right, we've come to what Jess Imran noted, which was we have T wave inversions V1, very deep in V2, V3, V4, really all the way to the apex, as well as actually extending to lead 1 and AVL as well. The ST segments are neither elevated nor depressed, and there's no pathologic Q waves looking at all these same leads. So the main finding here is diffuse anteroapical symmetric deep T wave inversions. Now, quick comment on the U wave before we get into sort of interpreting what these T wave inversions might be. That was a really great catch, Jasimran. I agree with you that in lead 2, these little post T wave bumps, but also in lead 3, see this little thing? That's not the T wave anymore. It's not the P wave yet. And here it is again, right? And in AVF, you're seeing that as well. And in fact, these little positives here too, there are U waves. And the differential for U waves includes hypokalemia, as you mentioned. Any cause of bradycardia can actually generate U waves, including this patient's current sinus bradycardia. Digoxin can cause U waves. Shoot, I'm missing one. LVH is associated with U waves. And then finally, in some settings, U waves can be an ischemic sign. I forget exactly the detail. It's not a very common or specific one, but U waves can be an ischemic change as well. Okay, but most notably, the CKG has these deep anteroapical T wave inversions. So the question is, what is the differential for those? And what on that list of causes overlaps with chest pain, and specifically potentially resolved chest pain, transient chest pain? Let's pause there for a second. Steph, how much more stuff is there here? Like, is there another good aliquot, or should we throw that last question I asked to Kirtan and Travis?
The only additional aliquot I'll give is the next several hours in the ER, how she did.
Can I make one comment on the EKG?
Please.
So one thing, she didn't have chest pain with this EKG. If she had chest pain with the EKG, I think it says a lot. But since she doesn't, and it still looks bad, I think also says a lot. But someone comes in, hey, I had chest pain 30 minutes ago, now it's gone. That EKG can be deceivingly normal. So remember that, to know, hey, did you have pain during that? I think that's one thing. And the other thing too, I always find that people get tripped up on with EKGs. And Zavan, I liked your approach to it. I've never, as far as putting the QRS in early on, that's a great point about that. So I'll definitely make sure to teach that. But sometimes having some leads that look, the baseline is wavy. Like if you look at lead 2, trying to interpret ST segment changes in lead 2, lead 3, AVF 2, it's confusing. So what I would do is not focus on that. Go to a lead like V2 and V5 to find a P wave, because you're going to get confused. The EKG might read a flutter because it sees all that. So don't focus on those, even though the EKG says a flutter. Go to a lead that has a normal flat baseline, and take that approach, and you won't let those leads like lead 2 confuse you.
Love it. Thank you, Travis. So I hope people were looking real quick, but
I don't know if you were sharing it or if it was just sharing the current one.
No, y'all were seeing me pull up the different EKGs, right?
Yeah, I was able to see it, I think.
Okay. So this is the April of 2021. I don't know what was happening here, but just very quickly, those T wave changes were not there. The U waves were there, in fact, even more prominently so, right? And then go ahead, Steph.
I just want to make sure. Could you guys see the new one? Because I can't tell if it's only sharing this one. You could see the new one? Okay. Oh, excuse me, the prior one. Okay. As long as you're sharing desktop, then they'll be able to see it.
Okay.
Now you're sharing, I think, only that folder.
Do y'all see this EKG blown up?
September 2nd?
Yeah. You do?
I don't see it blown up, but we can see it on the screen.
Oh, okay. Hold
We'll
on.
just share desktop, and then it'll show everything you pull up as you're doing, as opposed to that. So share desktop. There we go.
Oh, I see. Sorry about that. Okay. So, okay, April 2020.
2021.
2021, my bad. So no T wave inversions anteroapical, prominent U waves, even when the patient wasn't quite as bradycardic. Fine. And then 2 weeks prior.
And I'll say this was a quick check for malfunctioning fistula. For whatever reason, EKG was done during that ER visit. Zero symptoms at all. This is 2 weeks ago.
Interestingly, at that time, she had some anteroapical T-wave inversions, but nowhere near as deep. And then also in 1 and AVL. Okay, and then the follow-up EKG after admission, I guess, very much the same as before. So Kirtan, Travis, what is your differential for these anteroapical T-wave inversions in general and in this context? Y'all want to sort of wrap up with that?
Yes. So basically what you told, that what are the common causes of T-wave inversions. So like left ventricular hypertrophy can be a cause of that. And another thing I mentioned in chat earlier, that once I read somewhere that whenever we have LAD insufficiency things, then you can give deep T-wave inversions. Those are classically deep symmetric T-wave inversions in precordial discs. So like V1, V2, V3, that is also known as Valence pathology. And when we have, then it actually signifies the impending coronary artery stenosis or impending acute coronary syndrome rather than the current syndrome. So the patient may be completely asymptomatic at that time, no chest pain, no symptoms, no dyspnea, nothing. But subsequently, let's say over a course of 2 or 3 days, the patient will suddenly collapse. So that was one of the things that I was considering. Apart from that, I am still not able to figure out that what's causing this tachycardia. And was it a one-time thing? I mean, that time heart rate was 50 and later on it jumped back to 70, 80s, but it was consistently 50. That was one of the things I wanted to figure out. And another thing, the patient is not hypertensive now. Patient was hypertensive only during that episode. And as Stephanie told us that patient was symptomatic only and only during that time. And the patient has not been symptomatic since then. So how high is our threshold to follow this patient? I mean, just because the ECG is abnormal, should we do some invasive workup or should we stop here? So that was one of my concerns. So yeah, that's where I am. Probably some sort of coronary artery ischemia, maybe a component of left ventricular hypertrophy, and probably impending doom kind of thing. And then Travis, can you help me that how we can move further?
Kirtan, I think all of those things that you're thinking, I am, especially the Wellens. And I think if you break down Wellens into a type A and a type B, a pattern A or a type 1 pattern has those kind of biphasic T waves in V2, V3, whereas the type 2 or pattern B has kind of deeply inverted without the biphasic component. And both of those, like you mentioned, are kind of proximal LAD insufficiency. So with the chest pain, with the EKG findings, I think, taking a look at this patient's coronary tree that's what we need to do. And I think all of the other things, would come after that. So what I probably would do with this patient, and even though the troponin isn't elevated, it takes sometimes 2 to 3 hours for that troponin to be elevated. I think we all have had someone who comes in with a STEMI and the first troponin is negative, depending on if they had pain within the first hour, if it's been going on for 2 or 3. So I don't let that dissuade me from making a clinical decision on getting interventional cardiology involved, with this patient who is sick and has, chronic medical conditions. So that's the first move that I'm making. And of course, a chest X-ray.
That was awesome, guys. Thank you. Were you gonna subsequent, or can I just make one more?
Please, and then I can tell you where we are right now.
So just real quick, Kirtan, I just want to address something Kirtan mentioned because I think it's so important. He listed left ventricular hypertrophy as a cause of T-wave inversions, right? And one of the most challenging things I found, early on as an EKG learner is I learned that like T-wave inversion is ischemia, right? But most of the time when I would point them out to my supervisors, and attendings and stuff, they were like, yeah, nah, that's something else, right? And it was like, okay, there's all these exceptions, right? All this differential. It's one thing to be able to identify a finding, and then there's a long list of different things that can cause them, right? And it's just very challenging for that part. So T-wave inversions are very, very commonly caused by LVH, okay? But an important thing is that those T-wave inversions should only be in the leads where you have prominent positive voltage, okay? So look at 1 and AVL here. So this patient probably does have some degree of what you could call, LVH. The positive voltages is going to be in lead 1, AVL, V5, V6, right? And in those leads, the typical change is a slight ST depression, slowly going into a T-wave inversion here, and then more quickly coming up, kind of like a backwards check. All right, that is typical repolarization abnormality in a setting of LVH, and that should be a chronic change. But the T-wave inversions that we were seeing before that are happening now, that is not typical of LVH, right? And in fact, in patients with LVH who have a lot of negative voltage in the early precordial leads, V1, V2, the T-wave should be positive, should be very positive. In LVH, the T-wave points opposite the QRS most of the time. So this is, like y'all are saying, most concerning for anterior territory ischemia. I will say that both Wellens syndrome, as well as in this case, what may be happening is a degree of what's called reperfusion changes. So remember earlier I was saying you can learn from your patients, even from what happened to them 6 years ago, by looking back at the medical record, right? So next time y'all see a patient who has a diagnosis of a history of STEMI, go back and look at their presenting EKG, right, for that STEMI. 2014, September, they had a STEMI. Go back and look at that first EKG in the ER on that hospitalization. ST elevations, right? Awesome. Then that patient probably got rushed to the cath lab, but look at their EKGs over the next couple of days. And what you'll see is that once that coronary artery was opened up and flow was restored, the EKG evolved subsequently, frequently by developing deep symmetric T-wave inversions like this, which are called reperfusion T-waves. So it's possible that during the dialysis session, this patient had significant anterior territory ischemia, could have been a coronary event, could have been a clot, could have just been severe ischemia in the setting of supply-demand mismatch, as Kirtan was saying, just that hypotension. And then the resolution of that ischemia is resulting in the current EKG pattern. I also want to mention 2 other important differentials for this pattern of T-wave inversions in the anteroapical leads. One is what I will globally sort of refer to as a stress cardiomyopathy. That could be your classical, Takasubos in the setting of emotional stress, but also what people refer to as cerebral T-waves in a setting of a big stroke or a head bleed or whatever, which is thought to have a similar pathogenesis of just a huge sort of norepinephrine adrenergic impulse that affects the myocardium. And then remember that the right ventricle is the anterior ventricle. So your anterior leads not only represent the anterior wall of the LV, but also the RV, and pulmonary hypertension, either acute or chronic, and massive PE or chronic pulmonary hypertension can also cause anterior T-wave inversions, not too dissimilar from this. You don't always expect those T-wave inversions to extend to the apical leads and to the lateral leads, but sometimes they do, depending on where the leads are placed.
Awesome. I will just tell you where we are and then turn it over to Chiara for some teaching points, but I appreciate the opportunity to, again, always share an open case, but particularly to draw in an EKG, which is a data point we often really need, and in this case was the concerning parameter in her. She remained completely asymptomatic with normal blood pressures, persistent heart rate in the 50s throughout her emergency room stay. The subsequent troponins were exactly the same as the first one, 0.05, 0.05. Her subsequent EKGs, which to Travis's teaching point, I'll emphasize, were in the absence of any symptoms, looked about the same. I'll just say perhaps the anterior T-wave inversions were a little less pronounced, but they were still there, new from April of this year, although present but less dramatic 2 weeks ago in early September. So this is where we are right now. Because of the opening the schema for something bad about to happen, or whatever, Kirtan, however you said it, impending doom, we did tell her, even though she really wanted to go, we're worried that there could be something kind of going on. So we are kind of awaiting a little more evaluation for her cardiac status. I hope that this is just reflecting either her cardiomyopathy, since the changes were there 2 weeks ago, but we ultimately thought it was a pretty high risk situation. And to use Travis's words, she sort of underwent a stress test with hypotension and dialysis, and a bit worried about has something happened in her coronary anatomy since December of last year. I will update you guys though, and otherwise turn it over to Kiara to highlight some of the teaching points. Thank you.
Thank you so much, Steph, for presenting this case. It was a very beautiful case and expert discussions. So we had a female patient with a past medical history of ESRD and coronary artery disease with some stents previously. So she developed a chest pain after her dialysis, and this chest pain resolved after that. So we had a great beginning with just Miran, that he told us that when we have chest pain, we have to consider lungs, heart, maybe the endocardium or pericardium, also the muscles and the chest wall. About the dialysis, this is an important concern because patients with dialysis can develop hypotension. Not all patients develop hypotension, and most of the cases there is like a predisposition. In this case, this patient had some cardiovascular diseases. So this can occur because the cardiovascular compensatory mechanisms are not working well, or maybe because the patient is under medications that can compensate the less fluid or the less volume on the body. So maybe this patient under metoprolol cannot increase, for example, her heart rate, and cannot compensate the volume loss. And also we have to consider on this hypotension, maybe this patient have some dietary or health behaviors that make her predisposed to not compensate that well. Also, when we have a patient with dialysis for a prolonged time, we can consider some infections like a trigger cause. We also have to think about that this patient is under uremia, and when this patient is under uremia, we can have like PTH and phosphate levels up. So these are like very risk factors important for cardiac remodeling and maybe all the diseases that this patient is having right now. Also with uremia, this patient can be having pericarditis at the beginning, and that can stop at the time that the chest pain stop, and maybe in another case, the patient could have developed a pericardial effusion. Also, we have two concerning medications in this case. First, ticagrelor, that I didn't know, and thank you, Kirtan, for telling us that ticagrelor can trigger dyspnea. And also, we had that prolonged antiplatelet medication can predispose to bleeding, that maybe can be a component for the pericardial effusion. Also, we had that this patient presented U waves on the EKG, and thank you, Steven, for the master class of EKGs. So U waves can be present on hypokalemia or bradycardia or digoxin medications, ischemia, or LVH. And finally, we have that this patient had a T-wave inversion. So I didn't remember that. Thank you for make me remember that Williams syndrome can mean that there is like an LAD stenosis or LAD insufficiency, and this can present into types. Type A, that is like biphasic T-wave inversion in V2 and V3, or type B, that is like a deeply inverted T waves. Also, T waves inversion can be presented in like is called like post-ischemic T waves, that is present when we have an ischemic event and there is a reperfusion after, for example, the blood pressure is restored, and you can have those T waves on the EKG. And finally, we can have some pattern of T wave inversion in stroke, and as Saber remind us that precordial leads are not, they don't only mean the left ventricle. You also have as the right ventricle is like in the anterior part of our body, precordial leads can also mean like some pathology on the right ventricle. So pulmonary hypertension, chronic especially, can present as T-wave inversions. So thank you so much, Steph, for this amazing case, and I learned so much.
Thanks to all of you for your input, great teaching and thinking out loud. I have more information next week. Have a great Wednesday. Bye, everyone.